How are you doing?
Amanda. I can't see you at all. It still says waiting for others to join on mine.
Oh, that's very strange. Let me just solve the participants. Haven't got any in the in the waiting room. Do you want to try leaving and coming back in, just in case it's something on your system, Juliet? Because I can see, I can see you, as it were. We'll just wait a moment if people are having trouble getting in. Right, so I really need to check whether I've got my first speakers here. So I don't think we've got Witley yet, so we will wait just a moment longer. Oh, maybe we have. Yes, we've got Witley. Excellent. We've got Witley. Marvellous. Sorry, Witley. I was looking for you under your surname, and you were hiding in the participation list under your first name, or vice versa. Vice versa, I think. And have we got Helen as well? I think we might not have Helen yet. Okay, well, I'll start the welcome and introductions, because what I say really isn't that important. In that I'm just kind of the grout that sticks the important bits together. Welcome, good afternoon. I think you all know me, but I'm Amanda Allard. I'm Assistant Director from the Council for Disabled Children, and Lorraine has just very helpfully told me that Helen is now here. So hopefully you are here because you are expecting that this is a little seminar on children who are extremely clinically vulnerable, and how we can make sure that as many of them as possible feel confident about attending school. That was what Minister Vikki Ford asked us if we would do in this seminar, and just share some of the kind of good practice examples, where we've got a couple of you speaking later on from the field, as it were, about what you've done to address the issue. Obviously, there's been some issues about the original shielding letters not necessarily always having got followed up yet because of the numbers. So we've got some really good examples from you. But what we wanted to start with, because we know that obviously the guidance has changed over time, to start off with DHSC and DFE just presenting for us what the current picture is. Then we've got Sophie and Lorraine and also Jane from NHSE and PHE, just talking about what they have done already nationally to try and make sure that only those children who need to shield still are shielding. But can I, Helen and Witley, who am I passing over to first?
So I had a conversation with colleagues, Amanda, and I think Witley and Mike Ross are actually going to lead this.
Oh,
we decided afterwards, given that this applies to all children who are clinically extremely vulnerable, but I of course will be on hand for anything SEND specific that comes up.
Marvellous. And Lorraine has very helpfully also reminded me that Jane isn't from PHE at all. She's from NHS Digital. Sorry, my brain is slightly fried at this point now. So apologies for that, Jane. And also what we are delighted to be able to say, and that I had forgotten, is that Sue North is able to join us because Sue's been leading on clinically extremely vulnerable around the issue of, well, I think more generally, but obviously has a particular knowledge around the Down syndrome issue and adults with Down syndrome who've now been added to the clinically extremely vulnerable list. So, but sorry, back to my original, and I'm sure you've just answered it, Witley, but are you starting or Mike?
Yeah, so I'm very happy to sort of run through what the current shielding policy is. I will start by saying that I'm having some issues with the connection. It might not only be me, but Amanda, you're sort of breaking up a little bit. So if I'm breaking up for others, apologies. Very happy to share the slides, which I'm going to present from after the session. I think, Daphne, you've got the slides. Is it okay if you share? Thank you. So just by way of introduction, I'm Witley Rookwood. I work in the shielding policy team at the Department of Health and Social Care. And yeah, I'm just going to give a sort of that once the slides are up. Brilliant, thank you, Daphne, thank you. So if we just go to the first slide. Currently, the guidance to clinically extremely vulnerable people is that they shouldn't be shielding. So on the 2nd of December, following the kind of 4-week period of national restrictions when shielding was in place. And the updated guidance is now based on tiers. So as you'll probably all be familiar with, from tier 1 to 3, there is different advice to the entire population, but our advice sort of sets out some additional things that people who are at highest risk from COVID can also do to keep themselves safe. So that's things like, keeping their social interactions low, choosing to travel if they require public transport at sort of quieter times, etc. So there's sort of a whole host of additional advisory steps that clinically extremely vulnerable people can take, which is in our guidance. Any updated shielding guidance, which is, I'll reiterate, not in place at the moment, we expect to be a lot more targeted and only in place in the sort of very worst affected tier 3 areas and for a limited period of time. And if that advice does come back into force, then everyone on the shielded patient list will see a letter advising them of this. And just to also say that shielding advice is always for the individual and not the household. And we'll kind of get into kind of some of the questions that I know have come up about that a little bit later. So advice to children and young people, we can go to the next slide. So the UK CMOs issued a statement to schools, on schools and childcare reopening. And essentially, to summarise that statement, there is an acknowledgement that there's a very low risk of severe disease in children and young people from COVID-19, and schools will have their own measures in place to limit the risk of transmission. DfE colleagues will be able to expand on what that is, but that's very clear in their own guidance. So the advice at the moment is that all pupils and students should continue to attend educational settings at all tiers, and that includes those who are clinically extremely vulnerable. There is obviously a very small group of children who will have received specific advice from their clinician not to attend school, and that could be children who are, for example, immunosuppressed or have undergone a sort of transplant recently, that sort of thing. But those children will know who they are, the parents will know who those children are, obviously, and that's a very small group. So we don't really expect that that's impacting kind of attendance numbers that significantly. And yeah, if a child or young person lives in a house with a parent who's clinically extremely vulnerable, both now and when shielding is in place, the advice is that they should continue to go to school. Okay, so we sort of in the first slide run over kind of what any updated children's advice will look like in future if it is indeed ever sort of reintroduced. And I guess this slide is really just to reiterate that if we are in that position, the communications will be very clear. Individuals will receive a letter explaining from when they have to shield, how shielding will work, and for how long they have to shield. And during that time, children who are clinically extremely vulnerable, that's the only time we're advising them not to go to school. And again, that will be set out very clearly in any sort of communications that is sent out at that time as well. So those are kind of the main points, quick tour through what the guidance is at the moment, but very happy to take questions if anyone has them.
Do you want to put your hand up so that I know if anybody has any questions? Anything that Witley said that you didn't know that has surprised you? Or John?
Was there a second slide there? I thought you said there was 2 slides. Maybe I missed the first one, did I?
So there should have been 3 in total. I was sort of reading from looking at my own notes on the side, so I might have sort of been talking to a slide that hadn't yet come up. But is there any particular slide that you'd like me to put up again?
Daphne, do you want to just run through them from the beginning, and then John can ask you to stop at the one that he missed?
It was just I wanted clarification again a little bit about what you were saying about the children who needed to shield with their parents. So, for example, I was getting a bit confused about pregnant women shielding at home and whether their children could go to school, or whether it was, clinically extremely vulnerable adults and their children going to school. I was just getting a bit confused about that. Sorry.
Okay, no worries. I can clarify that. So at the moment, nobody should be shielding. So even if you are clinically extremely vulnerable, an adult or a child, we are not, shielding advice isn't in place, so nobody should be shielding. However, if it is reinstated, then if the child is clinically extremely vulnerable, then they should not be going to school, and that advice will be very clear in the notification. But that advice applies to the individual only. So if there is a CEV adult in the house, the child isn't CEV, they can still go to school, sort of thing. So it's very specific to the individual person. So in the case of a pregnant woman shielding, who should only really be shielding if they are CEV, then that they can still they should be able to send their child to school. And I know that some parents have had concerns about that, and there have been some correspondence on that particular issue, which we have picked up and have made the DCMO's office aware of. But at the moment, that is the advice.
Thank you.
Thank you, Witley. And I think we've got another question from Jill Ellis.
Hi, I'm just wanted to follow up on that, Witley, to say that the issues I'm finding is that if it's a single parent who's extremely vulnerable, they're really scared of getting COVID, because if they got sick, there would be no one to look after their children. And so they feel that it's best to keep their kids at home and reduce the chance of getting them getting ill, because if they did get ill, they don't know what they would do. And I wonder what advice you would give in that situation.
Yeah, I mean, I totally understand that sort of situation must be very difficult. I know that, and maybe DfE colleagues can come in on this, head teachers do have discretion about granting leaves of absences. So in cases like that, there is kind of discretion there, and it will be down to the individual school. But if, that parent felt that very strongly about the issue and felt that they find it really difficult because they maybe didn't have a wider support network, then that could potentially be something that they could sort of take to the head. And I should also add that in times of shielding, for single parent families, regardless of whether they have CV children or they're CV, there is sort of a bubble provision as well. So another adult would be allowed to kind of help out potentially, or another family if that were the case as well. But I'm not sure if DFE colleagues want to jump in on the kind of
I'm just wondering, Juliet, before I come to your question, I'm wondering whether it'd be helpful if we get Mike to do the DFE position, and then we can take questions, because it might be then we're clear on which side clarification needs to come from, if that's all right. Is that all right with you, Mike, if we move on to your presentation now?
Yeah, sure. Thanks, Amanda. In terms of the position, DFE does recognise obviously that there will be anxious parents, and as has just been alluded to with single parents in particular, and we have indeed received other inquiries from CEV parents who are concerned about sending their children to school. So there are protective measures. There is a system of controls which colleagues may be well aware of. So the schools have been already asked to implement a range of robust protective measures to reduce the risk in the school, and those are the familiar ones. So face coverings, cleaning hands, enhanced cleaning regime, minimising social contact, and ensuring that occupied spaces are well ventilated. But we also recognise that there can be no one size fits all here. And we were in discussion with ministers earlier in the week on this position. So if parents do have concerns, then what we're asking them to do is to discuss the protective measures with the school, and any other arrangements that can be put in place to ensure the child can still attend school. Clearly, it is recognised that school is the best place for the children, and not to have an extended break in education. But notwithstanding that, we have asked that the schools do bear in mind concerns of pupils, older students, parents and households, because they may be reluctant or anxious. And Witley, thank you for mentioning it. There is a leave of absence available, which I know has not been publicised within the guidance, but the schools are clearly aware of this. So the parents can apply for a leave of absence for their child, demonstrating why they believe the child should be out of school, and it would be then for the head teacher to consider the merits of the application and decide whether they agree. And just finally, I think touching on sanctions, we have been clear that sanctions against parents for non-attendance should be very much a last resort. So we don't want parents worrying about that. And we're not, to date anyway, aware of any cases where a school or local authority actually have pursued any sanctions against parents. And I suppose one just final point on remote education, whilst we expect the pupils to be in school, where a pupil is unable to attend because they're complying with clinical or public health advice, then the school will be expected immediately to be able to offer remote education. I'll pause at that point because that's probably quite a lot to take in, but that's just in addition to what Witley has, has already supplied.
Okay, that's really helpful. So I'm sorry, because I've now forgotten who it was that had their hand up that I suggested pause. Did you want to come back in? Oh, there we are. Julia. I thought it was Julia. And I see you in the list, Julia.
I know, you've seen enough of me today already. I was only going to ask, Witley, really, was the terminology of shielding. I was under the impression in the summer that we were asked to sort of use that so much, unless I misinterpreted that directive or it got misinterpreted or it was way to me. But I did wonder, when you were explaining or trying to clarify what somebody who's got the advice for somebody who is CEV, it does feel that the guidance is different to the original shielding, and whether that's why there's some confusion about what somebody with CEV should or shouldn't be doing, or their family should or shouldn't be doing, because we're still using the same term but meaning it slightly differently?
Yeah. So the kind of what shielding actually has changed since March for sure, and I would say that the kind of the last shielding exercise in November was slightly different in that we, for example, were advising that people could actually leave the house for a walk, for example, to get some fresh air, because we are finding out more and more about the kind of mental and well-being impacts of shielding on individuals. Whereas in March, shielding was don't even leave the house, don't sort of go, keep the doors closed, windows closed, that sort of thing. So it has changed slightly, but just to be clear, shielding was in place from March through to August for most CEV people. Actually, it went on beyond August for some areas in local lockdown, and then it was paused, and then we've only just recently at the start of December come out of a second round of shielding, which started on the 5th of November. So shielding has actually only kind of officially been in place twice, for a quite extended period of time, the first time and then the last lockdown just for the 4 weeks. So yeah, I know the term is used quite interchangeably. For example, our guidance is called shielding guidance, but actually for the most part it's advice of what to kind of do at each of the 3 tiers. So yeah, I hope that clarifies it a little bit, and I'm very happy to send these slides around after this conversation, and also signpost to the guidance online, etc., that can help hopefully clarify that a bit better. We also do have an infographic which I found quite helpful as well to share with stakeholders, and that sort of sets out what CEV people should be doing at each tier, if that would be helpful to see. Can share that too.
Yeah, you can, we can then circulate that with the slides. If you can forward that would be super.
Sure.
Natasha.
Yes, thank you. So I just wanted to clarify, because in my head I'm getting a little bit confused, because similarly to Juliet, I was under the impression that we didn't really use the term shielding anymore, and I thought that the Rcpch guidance had sort of given us the ultimate guide in terms of children, and was really clear about which children were clinically vulnerable and therefore needed to be effectively what I would have thought of as shielding, and that if they fell into that category, then they shouldn't go to school. So are you saying now that there's further updated guidance that on top of that Rcpch guidance, there is also a guidance around the different tiers for those that are clinically vulnerable?
Okay, so the Rcph guidance is the guidance that our guidance is based on, so it still stands. However, that guidance is on who should shield when shielding is in place. At the moment, it's not. So we're kind of not nobody is shielding. If rates of transmission were to increase significantly, say in the next couple of weeks, then CMO would take a call, and perhaps areas or the entire country would go back into shielding, and then those children who had been identified in that Rcph guidance would be advised to shield. I think NHSE colleagues will go into a little bit more detail about that process of actually offboarding lots of children from the clinically extremely vulnerable group due to that guidance. But yeah, that is exactly kind of what our guidance, and I've said guidance one too many times, I think, is based on. If that's clear.
Does that help, Natasha? I think I've seen the infographic that you're talking about, Witley. So it just says what should happen in each tier, doesn't it? And basically what it always says is children should go to school. But
yes, I think that's clearer. I mean, I hadn't realised that the Rcpch guidance was saying that children shouldn't shield at all now. I was under the impression that when it came out, the instruction was that if the child fell into that, I think it was a category A or whatever it was, that they were seen as vulnerable and therefore should not attend school. But it was a very few number of children that we're talking about.
Yes. So when that guidance came out, shielding was in place. So that report would have specifically
only applied then. Okay.
Yeah. Whereas we paused it in August. So once we paused it, that still does apply, but only if we are kind of under shielding guidance, which we're not at the moment. So if it helps, a helpful parallel would be to kind of look at when we're in a national lockdown. We've been in 2 so far. That's when shielding usually is switched on simultaneously, not all the time, but as in for the future that might not be the case. But whenever we've sort of been in lockdown, shielding advice has been in place too. Although for the first lockdown, that shielding advice was extended beyond the time that we were under a national lockdown.
So sorry to labour the point a little bit, but I think also the reason I'm partly confused, because I think it was in October or even in November that there was a letter that went to GPs encouraging them to update their lists based on the Rcph guidance, which seemed to me to indicate that that was all around whether there were still a few children that shouldn't be going to school. If we didn't have any shielding, why was that letter sent to GPs at the time? Sorry if I'm being very confused and silly, but
no.
Witley, do you want me to come in on that from the DfE guidance perspective?
Thanks,
if that will help. Yeah, sorry to interject there, but Natasha, yes, hopefully just to clarify, that list is still in place. If correct me if I'm wrong, but if we're referring to the children on what was the shielded patient list, then that is still in place. And from a DfE perspective, yes, all pupils and students should continue to attend under all local tiers, as Witley has alluded to. But the caveat here is that they should attend unless they are one of the very small number, which you've just referred to, a small number of pupils or students under paediatric or other NHS care and have been advised by their GP or clinician not to attend an education setting. So what you're saying, Natasha, is absolutely correct, that there are a very small number, and colleagues may correct me later in this call. We understand somewhere between 10 and 15,000 probably, rather than the 60,000 who we understand are currently on the list. But you're absolutely right, Natasha, that just hopefully to clarify that if the patients are being advised by a GP or clinician not to attend school and to shield, that is still the position. Hope that helps.
So thanks very much, that's great.
Just to clarify, Mike, there is a bigger group of children who would be told to shield during a lockdown, and there is a smaller group of children who might be advised directly by a clinician to shield whether or not there was a lockdown.
Thank you.
That just okay, fine.
Sorry to kind of interject again, just to be clear, because I think we're getting a little bit confused about the different groups here. So initially there were around 93,000 children on the shielded patient list. Then that advice from the Rcph came through, which advised that the majority of children didn't actually have to be on that list anymore. And ultimately, once the work has been done to take those children off the list, we should have a smaller number of maybe 10 to 15,000 children. And then within that group, there are another subset of children who have specific conditions and have been advised by their clinician. They are a very, very small group. I'm not sure the number, perhaps Sophi can kind of come in with that, but they are a very, very small number, and regardless of whether shielding is on or off, they shouldn't be attending school. But that's different from the 10 to 15,000 children, which we hope will, we hope to get the number down to that sort of level. They will continue to be able to go to school, unless shielding is reintroduced. So I think there's like two slightly different issues that we were sort of conflating, but I hope that's clarified it.
So Sophie's got her hand up, so I'm presuming that's because you've got more clarification to bring to light, Sophi.
Yeah, happy to. So I think part of the confusion might be coming from all the comms that was happening. So as Witley kind of correctly suggested, the initial shielded patient list had about 93,000 children on it. I think it was in the summer where Rcph held focus groups with clinicians to understand, based on our kind of recent evidence, who are the children who are clinically extremely vulnerable. In the summer, once we kind of found out that the proportion of children is actually a lot smaller than the list, we issued comms via single point of contact and directly out to our regional teams, including to trusts and practices across the country, asking for this review to take place and for clinicians to get in contact with families, making sure that only the children who are extremely clinically vulnerable remain on the list. This was reinforced with lots of messaging and is taking a while because of kind of some operational issues to actually get the list decreased. But that's why there's been lots of comms from NHS England, kind of single point of contact, regional teams, and directly out to practices across the country to make sure that we're reviewing the list. So it is only that kind of 10, 15, 20,000 children on the shielded patient list.
Oh, thank you, Sophie. And I think we'll sort of come back to that point, won't we? I'm aware we're sort of out of time for this session, and I've still got David and John again with your hand up. John, do you mind if I go to David first, because he hasn't spoken yet?
Of course.
Thanks, John.
Hi. Yeah, I think talking to some of our paediatricians, they feel they very much got everybody off the shielding list that they possibly could after the Rcpch guidelines, and they're still feeling that the people that they didn't take off the list are extremely vulnerable. So I think they're feeling a bit conflicted now, because the guidance doesn't really specify who this group who shouldn't be attending school now are. You know, and I think that they're kind of, the sense I get is people feel that's very much putting it back in their court with no particular guidance about how to make that decision.
Is that something that we need to take back rather than something that we can answer right now, do you think? Yeah?
I was going to suggest that. I think Richard and I can take that back to the Rcpch and to our clinicians and see if there's any further clinical guidance or review that we can suggest to make it more clear.
Okay, really helpful.
Thanks, David. It's really helpful to understand what the concerns are.
Yeah, and I was going to write in the chat, but I'll just say it. So I'm Richard Owen. I'm the head of children at NHS England. So yeah, I think that for the Rcpch guidance, it's important that that is clinical guidance to sort of setting the parameters for the clinically extremely vulnerable, but the policy around shielding is set by government and implemented through some of the NHS channels. So I think that's where it's got a bit confusing. I think if you read the Rcpch guidance in isolation, it's not necessarily always reflecting the national policy.
Thanks, Richard, and sorry, I didn't know you were here. Welcome. John, did that answer your question, or?
I think I would agree with everything that David said, because I think locally, when we got the shielding list, there was still an awful lot of children on it who shouldn't have been on it. And it wasn't clear whose responsibility it was to remove them from the list, even though they didn't meet the criteria of CEV. They might be CV, but they certainly didn't meet the criteria for CEV, but it wasn't clear whose responsibility it was. And we had to work with our special school locally, who actually took the initiative, to be honest, and asked about a group of children. And we were able to clarify that quite easily once we got the shielding list, and then we contacted GPs. So in the end, we had a much, much smaller number shielding, but it wasn't clear whose that responsibility was. And I think there are still children on that list locally who certainly don't need to be on it, but it's not clear whose responsibility is to remove them.
Thanks for that, John. I feel as though the next session might identify whose responsibility that is. So that's what I'm hoping. And if not, then we'll come back to that at the end. So Sophie, Lorraine, Sue and Jane, can I ask who's going first?
I'm happy to. I already gave some of my updates. There's not too much to update, but I can give a quick whistle-stop tour of the work that we've been doing. So following the kind of the revised guidance from RCPCH on which children might be extremely clinically vulnerable, we've done lots of comms out to the system, either via SPOC or directly to trusts and practices across the country, to remind them to kind of undertake this task. I think through our engagement, both with our regional teams and with clinicians on the ground, through the Association of Chief Children's Nurses and through the Children's Hospital Alliance, and with our kind of paediatric leads across the country, we quickly started to realise that this task was quite a bit more difficult than we thought, probably for the reasons you're all kind of citing. And we asked our regional teams to help us with this task and started providing weekly updates on numbers being removed across the country. We continue to monitor this and kind of strengthening our comms, reminding clinicians that this task should be completed. And that's when NHS Digital came in to provide kind of hands-on support to make sure that clinicians were able to find their data leads across the country in trusts to actually remove children from the list. So we knew that in some instances clinical reviews were happening and families had clarity in terms of whether they are or aren't on the list, but they might not have been kind of physically removed from the data list that we see. So there's been another big push, which is continuing from NHS Digital, to help clean up the list and make sure that the reviews that have taken place across the country are reflective in the data that we see. Jane has been doing a fabulous job on this. So Jane, I'm not sure if you're able to kind of give your update next in terms of all the work you've been doing with trusts and practices across the country.
Thanks, Sophie, certainly can.
Sorry, Jane, may I just interject? Sue needs to go next because she has to go to another meeting. So are you okay to hold on for 2 minutes?
That's fine. So, yeah.
Thank you.
Thanks, Lorraine, and thanks, Sue.
Thanks, everyone. So I guess I just wanted to give a bit of a different kind of update that's in relation to the addition of those who are over 18 with Down syndrome onto the clinically extremely vulnerable list. As I'm sure you will all be aware, a few weeks ago, the CMO made that decision based on evidence from the research about the impacts of adults with Down syndrome on the list. At the time, that the process by which that would happen is that GPs would be asked to contact anybody over 18 with Down syndrome on their patient list, that they would have a discussion with them around what that meant, and then with their consent, if they had capacity, add them to the list. Since that process was agreed, we're kind of in a bit of a different space, not least because of the progress around the vaccination and the prioritisation process around that for people who are clinically extremely vulnerable. So a further decision has been made that actually everybody with Down syndrome will now be automatically added to the list, to make sure that they are able to access the support that you get from being on the list, but also as that prioritisation around vaccination happens, that they are considered. So it's a slight change in approach, which is challenging, but the intent is to make sure that obviously those individuals are able to access all of the support that comes with that. We have heard and are aware that there has been some challenges for some young people and some adults in terms of their access to care and support when they have been identified as clinically extremely vulnerable. And obviously for young people that are 18 to 25 in college, the DFE guidance stands around that, and it's clear that it's for children, young people in school and college. But I think kind of weighing up the balance of the benefits of that automatic addition, that's the decision that's been made. And yes, just to clarify, it's adults over 18 with Down syndrome.
So I know you've got to leave. If anybody's got any quick clarification points, have you got time to take those?
Yeah, I've got a couple of minutes. Yeah.
Lovely. I think Vikki would like to come in.
Thank you. It was just a question really about the age cutoff, because we did quite a lot of research to see why the adults are more vulnerable and whether it was to do, you know, triggered by age, size, maturity of immunity. We found it quite difficult. So in fact, we actually did a risk assessment from 16 up, just because we assumed you were adult sized by 16. But it would be really good if there was any further information coming through around who would be more or less vulnerable. And also, of course, we're looking at those with more co-occurring difficulties. I mean, Shilpa will talk a little bit more about it when we speak, but anything more tangible would be really helpful in those risk assessments, please. Thank you.
Have you seen the research that kind of was produced and provided as part of the initial decision making around that? Because if not, we can certainly share the links for that.
That'd be helpful. Thank you. Shilpa?
Yes.
Yeah, so there was some research that I found on the RCPCH website, which I used. However, we've had some queries from parents of children with Down syndrome who are 13 or 14 years of age. So, you know, we just wanted to see where we should put that cutoff, and we were looking at other comorbidities and other illnesses and other problems that the child might have to be able to try and identify.
Yeah, so I think the research is really clear that, you know, the decision was it was from 18, so it was in relation to adults, and I think the research kind of evidences that obviously the older you are even within that framework, obviously the higher the risk. But we can we'll certainly share the links where the evidence around that came from. I'll send them over, Amanda, to you if that's okay.
That would be great, Sue. And if sort of when we've wrapped up, people still feel as though, because I think one of our concerns and really one of the points of this session, and which is why we've got Anna Gill speaking as well, sort of about how we support parents, is that communication with parents. So I think, you know, it sounds like maybe there's a bit of a gap there around, you know, how we talk to and share what the evidence is with parents in that age gap. So maybe that's something we could follow up with you, if that's all right. Jill, have you got a question for Sue? Or was that a hand of history, as we're now calling it?
Yeah, I'm one of the lead members of the Down Syndrome Medical Interest Group, so I've got quite a bit of interest in this. The first thing just to tell everyone is there's a really good talk on the DSA, Down Syndrome Association website, which was made for parents, where the researchers are talking, and I can put the link in that at the end of this talk, but great to show parents if they're asking. My next question, just to ask you, is are you saying all people, including children now, are on the extremely vulnerable list and just adults? Because that was, I misheard what you said. So just everybody over 18 so that they get the vaccine. Okay, so I misheard that. So I just wanted to check. But I'll send around now for the Down syndrome talk because it's great.
And there's lots of other really helpful information around this on you know, on a range of sites, but particularly on the Down Syndrome Association site, who have kind of been a key supporter in getting all of the information out for families and individuals.
Yeah, it's great. They talk through all the research. It's really clear. I'll send it now.
That's super. Thank you very much, Jill. Very quickly, Natasha, did you have a question?
Apologies, it's a legacy hand.
Oh, it is a legacy hand. Okay, I think we've just got Shilpa then, Sue, and then we will let you go. Thank you so much.
Yeah. Sorry, I just wanted to clarify. So I also saw a document with some research information which was on the DMO DCO forum, and that was a document which had quite helpful information, but it didn't have any references or where that information had come from. So I'm just wondering whether that information on the Down syndrome website had been updated at all.
I think that's probably not a question for Sue. Can we let Sue go, Shilpa, and we'll follow that up with you, and if we need to ask whoever it is to provide some references, we will. Thank you so much, Sue.
Thanks so much. Bye.
Jane, can we bring you in to shed some light on your Herculean efforts to get children who shouldn't be on the list off the list?
Yes. Right. Thank you very much for inviting me to have a chat today and talk. I work for a team called IBC, which is a team within NHS Digital that does implementation and business change. So I joined about 2 months ago onto the SPL programme to work with trusts. I'm working at the moment with more than a handful of trusts now to find out what to identify blockers that have prevented the review or the speedier review of the children and young persons list. And in doing that, so we've been working for about 8 weeks with, I'd say at the moment, it's around 20 trusts that we're working with, although it changes week on week. And in doing that, we've identified, or we were able to help to identify a number of blockers, which were mainly around the data fields that we were providing to trusts, so the amount of information that was able to be extracted on a weekly basis as part of the SPL. That changed on the 17th of November, and the data set was greatly increased. That's one of the things that I think that we've done to improve the situation at the moment. And we've certainly seen some the numbers have been reducing further. I think NHS England as well have very helpfully produced a number of data flows. So there was one that the data flow for data trust leads, one for clinicians, and also one for GP. And sorry, it's raining really hard where I am, so you might be out of the rain. And those data flows have also, they've been useful when we've been working with trusts to actually confirm the process that trusts should be using, and who should be involved in the process. So the other thing that has come to fore is that we need to confirm the existing nomination of trust contact. Many trusts gave a nominated COVID-19 trust contact at the beginning of the pandemic, but those nominated contacts haven't been updated in all instances since then. So actually, one of the things that came out from the work that we did was that organisations came to us and said many clinicians didn't know who their data lead was, that they needed to provide the information actually to. So that's one of the functions that we want to be able to do as part of this process, is put organisations that aren't maybe in touch with each other, the two departments, we're able to make that connection for them. I think as one part of the work that we've been doing this week as well, the data fields that we have provided go some way, a long way, to help us to be able to review the patients in a more robust data field. However, I think that what's coming through from some stuff is that we might still need to provide some guidance on how those data fields can be used to their fullest extent to reduce the list with the feeling of confidence to its fullest extent as well. So that might be something that I say at the moment, I think it needs to be in development, or we will have to develop further with an additional guidance around how you use that extended data set. At the moment, as I say, I'm working with the 21 trusts that have the largest number of patients actually on the SPL. But we will start working with trusts where they haven't made a submission since in several months, especially since before September. So that will be the next, once we finish with one set, how our work progresses. That was an update from me. I mean, if there's any questions, very happy to take them and to pass on links if people need it to the information. One of the other things, I might just move out of this room. I'm really sorry, I can't hear myself talk. Can you still hear me?
You are a little bit muffled, Jane. So why don't you take? I'll tell you what. Why don't you take the time to move? We'll get Anna to do her presentation, and then we'll come back to any questions for you after that, if that's all right.
Thank you.
Anna, is that all right with you if we come straight to you, and then we can sort of do any remaining questions together after you've spoken? Thanks, Jane. Can we get you to put yourself on mute? Thank you. I do feel for Jane. I also work in a conservatory, and it can be completely deafening. It can be many things. It is not an ideal working space. Let's leave it there. Anna, are you?
Right, thank you. I think Daphne's got my slides.
Daphne, could you share?
Lovely. So for introduction, I'm Anna Gill. I know quite a few people on the call, which is great. Colleagues I hadn't seen for a long while. And Amanda asked me to do this, I assume for various reasons, one of which I was doing a workshop this morning in our conference. I'm an associate with CDC and have been for about 10 years. I'm a nurse by background, but I am a parent carer of a young person who's been through and is living in this system at the moment, who is actually an adult. Therefore, it is for us quite clear he was CEV and shielding first time round and is now CEV and living a non-existent life in a residential care home, which again adds its own additional pressures. So I was asked to sort of think about supporting families. I'm just waiting for the slides. I know they always take a few minutes to come up. Don't worry, I'll keep cracking on. When they come, here we go. Right, well, my first slide is a quote from the Rcpch guidance that we've all been talking about. And listening to the conversations that we've had, you know, for the last half an hour or so, I'm really not surprised that parents are really anxious and really confused, because so is the whole of the sector by the sounds of things. Another role I have is I am Vice Chair of Cambridgeshire Community Services Trust, and we provide children's services through a large swathe of East of England. And so I'm seeing this from the provider perspective as well. Thanks. So what I've got at the top here is we have guidance, do we have agreement? And I got a sense that perhaps we don't really have agreement because we don't exactly know who these children are. As David has pointed out, it's very hard to know exactly who's in and who's not in, which makes it very, very, very difficult for families, because it comes down to the danger of it coming down to the relationships with your clinicians, whether you can have the confidence to argue with your school, whether you have the confidence to challenge, whether you close behind your front door and just hide. And some families have done that since March. And we do know, of course, there's been exponential problems with safeguarding and harm to children. But the main thing that is really kind of challenging for families is that even if your child is considered CEV, they can attend school, apart from those specific children that we've spoken about. The guidance is very clear that the decision is not on cohort, not on diagnosis, but it's down to individual clinical assessment and agreement with the clinician and the family, which again is putting quite a lot of pressure on a lot of clinical colleagues who've got families banging on their door saying, I really, really need you to say my child cannot go to school or does not need to go to school. And that is adding in pressure. Can I have the next one, please? So lots and lots of questions. Some of these we've covered already. I think the main one for me is how come my child was shielded and deemed at risk in April, but can go to school now, so what's changed? Now, people on this call, we all know the answers to all of these questions, or we know there's answers coming, but this isn't clear to families at all. All of these things I've put on this one slide have been taken from closed social media groups of parents of children with complex health needs through some of the national charities that I'm involved in. So whatever evidence says, whatever your clinical team says, how can you really believe that anything has actually changed? And yes, we know that we've got very clear evidence that children, even those that are CEV, are not at high risk of becoming severely ill. That's an awful lot of trust to place into the sector, to you guys, for the value of a person's child. There are concerns about who decides whether a child is CEV. There are concerns with some families where somebody in the GP may say, yes, CEV, don't go to school, they're too vulnerable. And then a specialist consultant will say no, or they'll start going around. We do know of cases where families will go around different clinical members of their team to try and get the answer, like a child asking their parents over and over again, until you get the answer that you want, that somebody says it's okay. So I was interested in this discussion earlier about leave of absence, because that's not been made clear. And there is a huge variation that we're picking up across the whole of East of England about children. We've also got in schools turning around to children saying, your child is too clinically fragile, too clinically extreme, too vulnerable, we can't have them, they're too scary. And I think that is really worrying. So we're having to work quite closely with schools and saying, actually, you can't turn around and say you cannot come. Down syndrome we've covered, but as somebody else put on a chat group recently, my son's 17, why is he not CEV now, but he will be in a couple of months' time when he's 18. There's a lot of concern about vaccine, about keeping children safe. I was approached lunchtime today between these two sessions from somebody whose child is, or young person is at Star College, residential college, where they've had a letter from the college yesterday, dated yesterday, saying that they are, although they are registered providing care, they will not be having the vaccine offered to the young adults in their care before February and maybe not till April. So the concerns and the mixed messaging that's coming out to families is very, very, very mixed, and people are really ramping up with their concerns. Can you do the next one for me? Thank you. Now, within Cambridgeshire, we had a group of parents that came forward to system leads, to the CCG, to local authority and everybody, and they wrote a very powerful letter of what they were finding and the impact on them, and we've got their permission to anonymise and share some of these. So families talk about being exhausted beyond belief and getting very, very little sleep, and we know the social pressures on families. We haven't even touched yet about digital poverty, about social poverty, and about the additional pressures that are really, really mounting up. A lot of exhaustion, a lot of fear of being drastically let down and being kind of forgotten by the system. And family talking very frankly about their own mental health. At a time where there was very much in the forefront of people's minds the mental impact that COVID has had, it would seem complex needs families have been left to their own devices to try and manage an unmanageable situation. So these are real stories from real families who are finding this is ramping up. And as we all know, as providers of whatever, wherever we work, we're all exhausted, but the families have got this exhaustion of never knowing when this is going to change. And so the pressures really are of huge concern. I've got another slide there, please, some more quotes. So we talked about well-being, mental well-being, the stress. A lot of their letter was about the impact on their children and on their children's learning and on their children's, the fear of them deteriorating during this long time. But the quotes we've taken particularly have been about on the impact of the whole family and on the parents. So kind of thinking about what have we done about it? It was very, very clear that communication was a huge issue. And that we needed to be much more frequently in contact and very, very clear. And so there's been some face-to-face meetings with a sort of group of parents representing a much wider number, but they're starting to put out fortnightly letters from the CCG. There were huge issues with PPE. There were huge issues with short breaks, with supporting children to go back into special schools, all the issues we've had with AGPs, etc. But in fact, we did find that communication made an enormous difference. And if families felt that they weren't forgotten and that they weren't left behind, that was making quite a good difference. The region, the ICS region, used COVID money to set up a hub for the local children's hospice. And we talked about that in the workshops this morning that will be shared out. And the evidence, and that has been written up as a case study. I think the biggest difference there was that the criteria for accessing a children's hospice were opened up to other children, not just those that were known to the hospice, not known to the palliative care team or continuing care teams, but families that needed a break. And they were given in little slots of 3 nights to try and help people realise that just a few hours was just not going to cut it, to try and help them. I think the pressure's ramping up. So my final 2 things are social media is doing us no good at all, as we all know. Huge scare stories, lots of fake news, lots of worry, and we're kind of beholden as a community, and I'm talking really as a sort of more as a parent carer community, of supporting each other and calling out those that are scaring. But I think one of the things that I'd say from a personal point of view is the pressure is ramping up. And when we're talking about now asking families to let their children go back into the wider world, back into education, people like myself are thinking, well, I've managed to keep my son alive since March. I've only got to go for another 6-8 weeks and he'll get his vaccination. And therefore, actually, I've started going back into being more protectionist and less and more risk averse. And basically, I've cancelled everything I was going to do over the Christmas with him. His pantomime's gone, I'm afraid. I need to keep him alive until he's got his vaccine. So I think we need to kind of think of some of these pressures that are piling up on exhausted families. And my last slide is just thank you. And to say thank you for what everybody is doing, because we appreciate this is really, really tough work, but it is appreciated. Thanks.
Thank you, Anna. You've made me feel a bit emotional now. Jane, are you back with us and without the monsoon?
I am. Can people hear me now?
Yes, yeah.
I'm so sorry, everybody.
Not to worry. So have we got obviously we had Sophie and then Sue and Jane and Anna. So just before we pass over to the people who are making this work in the field and on the ground, any questions or clarifications for any of our great speakers? I think they need a moment, Anna. Because we've got a discussion session at the end, so let's get all of our input out, and then we can have a nice interactive discussion then. And I realise I'm really sorry because I've obviously just forgotten how to chair now. Oh, John's got his hand up, because I didn't introduce anybody, I don't think, and I haven't asked you to introduce. Normally when we have a group this size, what I say is, can you just introduce yourselves in the chat? I know most of you know each other, but can you just in the chat say who you are and where you're from, just so that people who know you less well than Lorraine and I do know who you are. And I know there are a few newbies. John, did you have a quick question?
It was more a comment, really. I think I'm a interim DMO in Hackney and the City of London. We've had issues, just as Anna has described in her last few words, about people getting more protectionist at this precise stage. We've had a small number of families where they were on the edge of their children going back to school and now have become the opposite to that. But also, I think when we've been trying to get families back to school, or children back to special school particularly, when we have had a number of outbreaks, all the families get notified, and as Anna said, everything is on social media. And it's actually really hard sometimes to persuade families that the schools have very good measures in place.
Yeah, no, I think that's right. And thank you, John, for that. Now, we have got some more presentations for you. I'm just looking to see who is going first. I think Vikki is going first. Is that right, Vikki? Vikki and Shilpa?
Yes, I think that's right. Is it okay, Amanda, if I try and share from the presentation that Shilpa and I have done, if I can get it up? Will that work?
Can I just check, are we going back to Jane?
Oh, sorry, girl, yes, sorry, I thought we were only going back to Jane if we had more questions, but Jane, okay. Was there anything that you wanted to add on?
Nothing more that I need to add on. I mean, if anybody is still struggling here to get in contact, you know, with the person from their data lead in their trust who should be managing their removals or the deductions, then please get hold of me. I can put my email address in the chat if that will help people.
That would be absolutely great. Thanks, Jane. If you don't mind, that would be super. Right, I will switch my camera off so that we can see if we can preserve what little internet we have. And yeah, go ahead and share, Vikki.
Okay. So just while it's loading, this is a presentation from Shilpa and myself from Waltham Forest, which is really sort of what we tried to do in perhaps an imperfect world, how to support some of our families with this rather tricky business we were going through. Unfortunately, I'm not able to share. It doesn't look like it's allowing me.
I'll get it up. Then.
Can you see it, Shilpa? Thanks very much.
Have we got?
I'm not whether we're actually allowed to the system.
Oh, is it not?
Don't know.
I'm not sure. If you want, I can share it for you as well. I've got. If you haven't made any.
Who's that, Daphne?
Yeah.
Daphne, can we send it to you? Because we did some little tricky changes so we knew who was talking.
Yeah, for sure. You can send it.
So has Daphne got the most up-to-date one, Vikki, or
just
not?
Trying to send it.
Well, we only made tiny changes. Shall we just
Should we go with the old one?
Yeah,
Okay,
just
let's
go
for
with the old one.
Okay, yeah, definitely open it up. Thank you.
Okay.
Thank you so much.
No worries.
Yeah. So in Waltham Forest, just like many other places across the UK, we were looking at the number of, patients with COVID increasing across the world, and we started thinking, oh dear, what shall we do to try and make sure that our patients get the best care if we did end up going into lockdown, and if doctors needed to get redeployed into hospital, and then we needed to keep key services in community pediatrics open. I just started talking because I don't know.
Let's go for it, Shilpa.
Yeah,
I don't think it's
there's
coming up.
there's no slides at all, so I.
No.
Yeah, I'm trying to open, but
Oh, okay.
Is it very slow, Daphne?
Yeah, it's very slow. Worst case, I'll try another way to open it.
Okay.
Yeah. So what I'll just carry on talking in that case.
Why don't you talk about the early March, early March times? Yeah.
So we started looking at our patient caseload, looking at which patients would be, very vulnerable. Of course, at that time, we didn't have any guidelines. We were just looking at which are our most at-risk patients. We were also looking to see which children we'd need to make sure we see earlier rather than later, if patients were no longer able to get community pediatric input. So we used input from community pediatricians, also from our MDT team as well, because many of our clinics are MDT clinics. So our dysphagia specialist speech and language therapists, our physiotherapists, our specialist nurses, and our community nursing team, we all fed into the list of children which later became the clinically extremely vulnerable kids. We then shared this list with Vikki and our partners, so that where am I? Would you mind just going on to the next page, please?
Sorry, can you see?
Yeah, no, that's fine. This is the one that I'm talking about.
Is this it?
So,
Can you see my
Oh yeah, brilliant.
That's
okay.
perfect. Thank you so much. So we shared that information with our partners as well. A few of our children actually became unwell with COVID infection, a couple of whom did get admitted into the intensive care units. So we wanted to make sure that our information was as up to date as possible, and we were in liaison with the tertiary hospitals, so that any information that we got, we could try and apply that to our practice, so that we were keeping our children safe as possible, really. There was also training and question and answer sessions provided to the SENCOs via the SENCO forum, so that we were trying to communicate as much as possible with our partners about which children would be most vulnerable. Next slide, please. Vikki.
Okay, so we were notified that the guidance had been updated by the Royal College Paediatrics, and I think this was yours, Shilpa, and I know that Shilpa contacted all the children's parents, where the children were no longer considered to be in the children group, now in the CEV group, which was a smaller group, and divided into groups A and B. So having had a bit of a training from Shilpa on who that was and being confident about how to describe it, I went then back to all the SENCOs, and that was of the mainstream schools actually. The special school head teachers did a briefing for the SEN team and the parents forum about who was in the group A and then group B, and then how we were going to communicate with families in the group B around their risk assessments. And partly that was done in sort of parallel with the transition back into school. And we used a guide actually that Barnet wrote, a lady called Sam Rothwell, who's one of their advisory teachers, and updated into that something around a risk assessment around making sure that the children's EHCPs were implemented in school, and then consideration of whether the children had an original letter for shielding or whether they were now under CEV group, under Group A and Group B. And that guide was updated and sent to the schools for use in September, returned to school. So at that point, we didn't really know how critical that was going to be, but it turned out to be a fairly critical thing to have done. So can you go on to the next slide, please? So the Group A and Group B sort of descriptions, if you like, were put on every piece of communication I could possibly think of. So useful information sheets sent to SEN officers when talking to parents, so they were calling families they were worried about, or parents were calling them and they were sort of putting them in contact with different services, and they were then talking through this group A, group B, getting back to us if they were worried about anybody requiring support. We had a weekly call-in led by our AD from SEND with the parents forum, and they did sort of questions and answers about that. And we ended up really going through about 200 children, looking at their risks, seeing whether they fell into either of the groups, and obviously drawing on specialist knowledge such as the consultants, the GPs, the specialist nurses within the schools, and feeding back to SEND as well. We had some individual multi-agency risk assessments, which were held as sort of Teams meetings with parents, and we did some sort of general groups as well for those with things like the aerosol generating procedures. So we had a group of parent rep, we had head teacher, SEND social worker, CCG rep, DCO, SEN officer, and the special schools nurse, where we went through all of the children and looked at the services that they had, how we would be able to get them into school, which then changed slightly. And those who were in school, we had 10 in that group. And at one point we had 5 children in and 5 at home, and that really went up and down quite a lot. Next slide, please. So when we then had, this is just a letter that I wrote, just an example. So on to the next slide, please. When we then had the sort of call that this, and were notified about the next lockdown in November.
So
in fact, sorry.
Yeah.
Sorry,
so,
Josh, it's you.
So what we did was, rather than it just coming down to one paediatrician calling parents, we found that it's much better if the doctor who knows the child best is the one who's contacting the parents. So whether the child was being seen in an epilepsy clinic, or whether they were seen in a so-called virtual school clinic or a neurodisability clinic, the doctor who knew the child and family best was the one having that conversation with them. Sometimes the children were having input from tertiary centres as well. So if, for example, a consultant from Great Ormond Street would have done a conversation with them, we didn't recap over it again in the same, repeating everything that's been said again. But this way we were able to narrow down and make sure the children who didn't fit on the CEV list, the families were aware about, if there was another lockdown, what they should be doing. And if there was any confusion, who's the best person to, get information from. We also discussed with the schools, and rather than having schools asking Vikki and I about whether a child would need to be shielded or off school, we found if a child was having input from a specialist consultant, for example, cardiologist, that cardiologist would be liaising with the GPs. So therefore, in discussion with all the partners, we thought it was best that the school leads were discussing directly with the GP if it was a child who wasn't known to the community paediatric team.
Thanks, Shilpa. Yeah. I think what we found from this is actually the communication between schools and GPs and parent schools and GPs has significantly improved, although I think it's been an enormous burden on the GP practices to be having to lead on this piece of work, but it seemed to work. It was a little bit more done through circumstance rather than using things like waiting for the shielding list, and I think we got in fairly quickly on the days before the lockdown when we realised GPs were sending the letters, that I went back out to all our sort of communication links, so the parents forum, the GP lead just to check, the SEND officers, heads of special schools, the colleges, with an updated sort of information, and really emphasised that if the child was not in school, they should be asking the parent for their letter outlining that they were clinically vulnerable and explaining what that would look like and how the letter would look, etc., so that they weren't relying on the shielding letters that had gone out the first time round, because we knew that they changed quite a lot. And also used the same communication networks, but included the adult learning disabilities team around the new information for those who are now on the list who had Down syndrome or over 18. But in fact, because we weren't completely clear on the reasons why there were adults were considered more vulnerable, we actually went down to 16, so contacted the local colleges, local special schools, etc. In fact, I mean, just to give you some examples, that we did have 2 families and young people who discussed it in great detail with us. One of the young people decided not to go to school because she hadn't been taking her vitamin D supplements she was supposed to be taking, and she thought she would feel safer at school for that period, not at school for that period of time. The other young person really wanted to continue his college studies, so he wore PPE, including a face shield and a mask, and was very good at washing his hands and being careful about social distancing and aware of open windows, etc., and wearing more clothes as a result. So we'd had some quite good anecdotal feedback. I think that the types of things that Anna was raising around queries from families and the fatigue and anxiety and all of those things have also come up for us. It's a smaller borough, it's very densely populated. We probably can get to people maybe a little bit quicker, but I think we really recognise all of those things that were raised as still being actually there. So I don't think we've resolved that by any stretch of the imagination, but this was just one way to sort of keep the lines of communication very open, if you like, with our families. Okay, and then I think the last slide is
just questions.
Okay, thank you. Thanks, Shilpa. Sorry about that.
Thank you.
Yes, we're very happy to share our slides if anybody thinks they're useful. I think Michelle had a question.
Super. Yes, she did indeed. Shall we go through the other two presentations, and then we can just have some open discussion at the end. So hopefully Rajesh is expecting to go next, and we might, should we try the right slide set? We've even got the right slide set. Fabulous. Over to you. We've got the slide set. Have we lost Rajesh? He can't unmute. That is going to be.
Do you want me to talk it through instead? It's Juliet.
If
slides together.
Yeah, that would be absolutely fabulous.
Yeah.
Hopefully,
if you want to keep clicking, Marie, for a bit, because I think most of the initial stuff has been discussed already. But we just split it down. So this is a bit more of a confession about what we did and what went well and what didn't go so well. So we've been quite candid. So yeah, we're recognising that there were subtleties and differences, and the main point was that the specialist paediatric health practitioners were unaware of who was on or off the shielded patient list at that time in the first lockdown. So we weren't necessarily overly engaged in who was on and off the list at the first lockdown. So if you could move on, please, Marie. And the learning from that, as you can say, was that the GP coding might not have been specific enough, and we obviously awaited the guidance from the RCPCH as well. But in the absence of anything else, we resorted to the school's individual risk assessment and made sure that that was multi-agency and very robust. Worked closely with the heads of schools, going through the individual children on the school roll to recognise not only the risks from COVID, but the additional health risks and the additional safeguarding risks. So to understand whether the child was as safe or safer being in school as to being at home. So we were quite comfortable and confident with that at the time. And then obviously we had the updated information. Keep going, Marie. Thank you. So, and again, click again. Yeah. So we had the additional information there about shielding and the plea for cleaning up the list. But we still were unaware as to who was on the list. Felt that the capacity, so our paediatricians were used to support other work as well, and we didn't find the capacity within our services to be able to identify who was the list holder or how we could influence the list despite the guidance that we had, but also we were confident that we were using the individual risk assessments, and the communications with the parents and young people and with the schools was robust for their purpose and the needs. So if we could move on. So we knew then that obviously, oh, there we go, there's the learning. So we continued to use the risk assessments and the risk mitigation and using the terminology with Royal College of Paediatrics and Child Health Guidance, and obviously the AGP guidance. We were waiting for some information as well to be supportive of our decision making, but in the moving forward with the risk mitigation in the absence of any further guidance or support. So if you could move on again, Marie. So then we had obviously the second lockdown and the information there, and the list, so the shielding patient list was used and sent to the local authority, and they were under the impression that we would also have that list, and that became quite a stickling point as to who was the list, who was on the list, who had the list, who was responsible for the list. And as a result, we persuaded the local authority to share the list for the individual children on the school rolls with the head teachers. And then the head teachers were able to liaise with the local health providers as to who was going to be receiving a letter, because as everybody else has said, there was a lot of communication between families, with schools, with GPs and with health professionals about whether a child should or shouldn't have been on a list and had or hadn't received a letter as directed from the local authority as a response to the shielding patient list. So if we could move on again. So our learning was that we realised that the list wasn't up to date, and it didn't reflect the assessments that we'd done and the recognition of those that we'd already identified as clinically extremely vulnerable through the individual risk assessment process. So the paediatricians and the children's community nurses reviewed the school roles list with the head teachers and the families, and identified using the Group A and the Group B, and captured the symptomology and the diagnosis which led to the decisions, so that we had really robust recording of why we thought somebody may be at more risk or less risk safe or safer attending school. And then a local letter was created, and the letter itself was sent out to the families, prompting the recognition of the child's status and asking for them to make contact with the health professional to discuss any school attendance and any anxieties about school attendance. So again, it just prompted that local discussion. But we recognised that this letter had been sent out. It was done very quickly, so the schools in our area made the decision to close for 2 days while they identified which children were on the lists. And so it was done very much on a Thursday, Friday, recognising the children and sending out letters, and unfortunately that led to some errors in the letters and the use of the phrasing terminology about shielding, which I've already noted, already commented on earlier in this discussion. And the letters were sent out, and we acknowledged that there was, so you can move on, Marie, we acknowledged that there wasn't the opportunity for us to scrutinise the letter and correct any errors in the time frame. But out of those, the learning from the letters there, the two highlighted areas, the main thing was that at no point had we seen the list in inverted commas, and that hindered us to be able to either say whether the right people were on the list or the wrong people were on the list. So obviously, having done this workshop this afternoon, it's great to hear that Jane and we can contact about the data leads in our areas. The other thing, the more positive thing to recognise was that the individual risk assessments that we were using with schools and families were dynamic and they were accurate, and we had identified the right children who actually needed the support on the ground. So although the NHS digital list didn't support us and there was confusion because some families were getting duplicate letters, or some families were getting no letters at all about their children, or conflicting letters, we did feel that as far as a process of identifying the right children to have the right contact from the right clinicians had occurred. And obviously it was a rapid time frame which resulted in that communication being cleared up eventually, but there was a period where there was some confusion with families and with clinicians and with our local authority colleagues and the vulnerable sales group, which was the strategic lead in our area. So if you could move on again, So the actions were that we've learnt our lessons, and we've recognised that we need to ensure, and hearing the message of the presentation before about being clear about the communication and keeping families up to date with the information, and we need to update the shielding patient list and put some time and efforts into that, but we're not quite sure where the capacity is going to come from to do that. That's about it. I've rattled through that quickly, hopefully.
Thank you so much, and thanks for stepping in when Rajesh's microphone wouldn't play ball. So Marie, can you go on and share our final presentation,
That is mine,
please, which is from Lorraine.
Yes, hi.
Hi, welcome.
That's right. So suddenly getting a little bit of break in the communication. It's been great so far. So stop me if people can't hear me. So I said right at the beginning when I was asked to do this that I feel a complete imposter because I'm a jobbing paediatrician down in Torbay in Devon, and we don't have any rain down here today, which I'm pleased to say. I used to be a DMO, and I stayed on the forum because I found it very useful, and I just posted when we'd been doing work to try and find out where the list was and how we could get hold of it, and hence I was asked to share our journey a bit today. I'm really pleased to hear both that what we thought was happening with the list does seem to be the national idea of what's happening with the list, but I would also echo that it took us a lot of work locally to try and find out where the list should be. And I can still go, in my mind, go back to the meeting we were sitting in when we thought we had 100 children that, we needed to review on our list, which had been our local names put on the list. And then our senior community nurse just looked around and she said, I've just seen the list from NHS Digital and there's 4 times as many children on that list. And we thought we were sort of doing quite well. So that has been a real challenge. This first slide, this sort of path from NHS Digital round to the right was the journey that we had locally, bringing the list down to through to our community nursing team and to us as paediatricians. We had an interesting challenge because we were already having some multi-agency meetings with our local authority, and we misunderstood that they didn't have the list, so a reverse of some of the comments. But in fact, they did have a list, but they realised that it wasn't up to date. And so that was a really useful sort of conversation we were then able to have because they knew that we should be updating it. And we were then able to sort of move to another level of information sharing. In the middle of this, there's a big white area and an arrow, and that's pointing to the general practice and to our tertiary services. And we have not had been able to achieve a joined up working with the tertiary services and the GPs. And I think that for all of us to have seen the names on those lists and to sort of feel that we were all having to do that work ourselves has really made us less efficient. If we were able somehow to have more of an understanding about who was leading on the discussions with families, that would have been really helpful. And I don't really know what the answer is with that. If I could have the next slide, please. So again, we've talked a lot about learning about the process, where the list is, where it's coming from, and who updates it. Certainly, what we've come to the same conclusion that 75% of the children who were placed on the list initially certainly don't need to still be on there now, and it's probably even less than 25% need to be on there, and we still haven't got through reviewing all the children. But I think that going forward, hopefully it'll be a much smaller number of young people that we will be needing to sort of keep up to date with in such a high level. If I could have the next slide, please. So I think what we achieved was really because we are a small unitary authority. We've got very good relationships with our colleagues in the SEN team, and we felt able to have frank discussions that were probably outside what we were being told we could share as data. We are an integrated organisation, so we have acute paediatric services, community nursing, public health nursing, all in under one umbrella, which again made the data sharing easier. And we'd already been having regular SEND sort of meetings on a fortnightly basis, which we were quickly able to both upscale to weekly or more often, but also use as a network, communicating with each other. And on that meeting, we're joined by CCG, our DCO, our Children's Commissioner, and somebody joined who was focusing on the children with continuing healthcare packages. So those children we knew, were already being addressed. Really, it's much more the much wider number of children who probably didn't need to be on the list that we struggled more with. If I could have the next slide, please. So these are just a few of the challenges that I'm thinking of, and I think that a lot of this has been covered, but I would echo the experience on the ground. One of the things that we hadn't really appreciated what the needs and the challenges of the different teams and the different organisations were, and it was only by being able to talk to each other that we were able to get underneath that. So one of the key things we realised was it actually wasn't who was on the list, but what it meant, and that might be completely different for one person from another. So we've had children who are not in school, who school other people felt could be in school. We've got children who are in school who are on the list, who schools were being told, I mean, one school were told that they weren't covered for anything by insurance because those children were in the school. So as people have been saying, really mixed messages to families and to schools and to us as health professionals. We had not anticipated that we'd need to keep the list up to date at such a level, and when staff were redeployed during lockdown and communication was much harder, we were having to work in very different ways. We sort of breathed a sigh of relief when we thought we'd done the list. Then we found that it was 3 times as long as we thought it was, and we hadn't updated it. So that was something. And of course, by the time we were then calling families, as other people have said, they'd often have had different letters, conflicting messages. So, I think that's been something that was a shame that we missed out through the summer, that we should have been, doing that much more proactively. And of course, we can't tell who's on the list unless we go to a database, because in secondary care we don't have that coded in any way. So we weren't, even though we were making contact with families, we weren't necessarily thinking about that as a specific issue to cover. It was more a clinical discussion. We decided, doing risk assessment really across the whole team, what priorities we would set as to which children we would review first, and which we would need to leave. And I know local authority is saying that there's still an awful lot of young children who are not in school. There are earlier pointers as to if you've got a parent who's a single carer who's considered clinically extremely vulnerable themselves, or their sibling issues. So, for some of these, we've just done a sort of check. Do we think they're safe? Are they on any, child protection plans, whatever? Is somebody making contact with these families? And we've had to sort of, some of the children, their list status has actually become almost a lesser priority. It was very useful to have that wider adoption of the college guidance, of those criteria. I absolutely agree that it's been very difficult, in some cases to really give clear advice to parents, but we've just had to try and be honest that we're using the best up-to-date research we have. But it was really helpful that everybody was referencing to that same point. We locally anyway have peer review between consultants for complex cases, and we use that forum for some of the the children to try and just benchmark really on what advice we were giving, or what discussions we were having with families, because it wasn't something we'd rehearsed. It was really difficult to know how to have those conversations really. As far as sorry, just go back to that last slide, just a couple of last points. So as far as people talking about not knowing who was on the list and who else had might have shared information and whether we were able to, we just took a pragmatic sort of send approach, if you like. I just felt that, you know, potentially we had information that a child's health need might have changed and that might affect their ability to access education. So on a ground level, I think we were probably sharing information, having conversations that at a senior level we were being told they didn't think that we had the grounds to, but we just got on with it, really. What the last point I would ask if could be taken to note, I've been told still as of this afternoon that the children, when they were put on the list, had a unique code. And even though we've identified children who can come off because the GP have placed them on there or a tertiary service, we still can't get them off because we don't have that unique code. I know that's been escalated, but I think it's still the case today. So that would be really helpful just to clarify. Next slide, please. What we decided locally was if we ask the parents when we have a discussion with them, if we can share the information, we just really try to encourage colleagues to actually let the school know, let the SENCO know under that SEND umbrella. I think that, as you say, there's been a real mix actually of what it's meant to families on the ground. So it's been no one model fits all, really. Interestingly, the local authority had their list and did not share it with schools. They were very concerned about that. So we ended up saying, we're here. If you ring us and give us a child's name and we think that, you know, they might fit under the SEND criteria for any reason, or an individual healthcare plan that we now think might be out of date, then we'll have a discussion, and that's how we've done it on a clinical level. I think that is me. Thank you very much.
Thank you very much, Lorraine. If we can stop screen sharing, Marie, I don't know whether I dare suggest this, but I'd like to suggest that we all switch our cameras on, because this is supposed to be a kind of interactive sort of discussion session now. Jane, I wondered whether you were the right person to come back to on this issue about the list and who it can be shared with. My understanding would be that you would be able to share it even before the Coronavirus Act, but that you would definitely be able to share it under the Coronavirus Act, because it is about carrying out your, you know, what you are required to do to keep children safe. But, you know, that's I've got into trouble with my COD legal analysis in the past. So perhaps somebody who is better placed. Poor Juliet, you're looking very cold there. Or is that your Christmas hat and you're actually very hot but just jolly? Hot but jolly, that's excellent. So yeah, anybody want to weigh in on that?
So it's Richard here. So I think I'll try and find the link, because there is guidance about who the SPL, the shielded patient list, can be shared with. And I think it's mainly if it's commissioners and staff who are using it to, you know, support patients, then it's fine. But there is a list. I have had the query a few times of people in a bit of a panic about, oh, I've just shared this and am I allowed to? So I'll find the guidance from the NHS digital website.
That would be great, Richard, because then when we put the recording of this session up, we can put a link to that guidance, because that's obviously quite a significant issue. Sorry, Juliet, go ahead.
I was just going to say, I don't think it was the guidance barrier or the sharing conventions barrier. It was more that the people who had the list weren't from health. So the local authority were the people in our area who ended up with the list. And their assumption was that we had it, we being health, and we, meaning therefore I and Dr. Pandey as the DMO, hadn't gone to find it within health. So it was more, and yet we had no idea how, you know, we asked those questions many times. Who's got the list? Where is it? How can we update it? And we, between us, didn't have the networking within our own health localities to find that out. So as I say, it's really useful that Jane's here and being able to tell us who is the holder of the local list. But to get the local authority to understand that actually they were the only people in the area who had sight of the list for children and young people.
So that's really helpful. Thanks, Juliet. Obviously not helpful for you at the time, but very helpful clarification. Thank you. Any questions for any of our amazing presenters on their approaches? Anything that actually it worked for them, you tried and it didn't work? Anna. I think you're on mute if you're speaking.
Yeah. Oh, right, now I'm off. You didn't hear me swear there, did you?
No.
I think the messages that are coming out about inconsistencies, conflicting advice, and regional and local variations. So I think something that's going to come forward and really hit the fan is vaccinations for the 16 plus, and who is so vulnerable they get a vaccine and who doesn't. And I think it would be very, very sad if we fell into the same pattern of fear and rumour mongering and scare amongst families if that's not clear. So I'm kind of appealing to those that will be in a position to ensure that when there is clarity, that it's shared authoritatively and clearly. That's the next thing that's ramping up.
I think given what both you and John were saying about the way in which some families are almost hunkering down at this point, waiting for the vaccine, I think you're right, Anna, that will be particularly critical to get that communication and messaging right. Any thoughts on that, Richard and Sophie?
Yeah, I guess I'd quite like to know I guess we don't have the data at our fingertips of knowing how many families are doing that, but it'd be good to somehow get a sense of it. And I guess some of these families maybe weren't even on the shielding list at any point. They've just taken the decision themselves potentially. So I don't know if it's probably through the people on this call that can help us get some kind of sense of how many families we still think are either with or without the advice of a clinician are staying at home. So I think, yeah, it'd be good to be able to quantify it, wouldn't it, in some way? Because then we can take it back to our various organisations and say, what do we do about this? But without knowing how many, it's quite hard to do that.
Fair enough. So that's something, a work in progress then, possibly.
I think Wellchild and some of our voluntary sector partners would be quite interested if something went out on the DCOs, DMOs, commissioners' networks and things, and just as a general call out for a sense of it. I don't think I'm far off here. I think my ears are pretty close to the ground, and I think it is happening. And I'm talking about the 16 plus.
Okay, thanks, Anna. Any other questions, queries, points of clarification? You've had a lot thrown at you. Some of you who have been with me since 9:30 this morning, all day, but this afternoon, you've had a lot thrown at you about this issue. So, Shilpa.
It's just really a comment, really. I work in a NHS trust which goes all the way out to Essex in terms of the size of the NHS trust, and I found that I'm the only DMO in Waltham Forest, in Redbridge, Havering, and so on. They don't actually have anyone in a DMO type post. So in those boroughs, some of them found it very difficult to advise, parents and, regarding children going into school. And I just wanted to take this chance of saying that I think that the only reason we were able to do how much we did do in Waltham Forest is because both Vikki and I are both working together. We're both employed by the NHS Trust. Vikki works in the provider as opposed to the CCG. So I thought that was very helpful for us. I just want to share that.
Thank you, Shilpa. That's a really helpful clarification. Any other thoughts? I think you're just exhausted, aren't you? Oh no, Lorraine's coming back in. And maybe Juliet. Should we go Lorraine then Juliet?
Thanks. I just wondered if anybody would be able to take away this issue about removing the children from the list. So once we've identified they can come off the list, I understand still have a difficulty centrally. that they have we don't have the code, if you like, because we didn't put them on the list in the first place.
We can look into that with NHSD.
Thanks, Sophie. That would be great. And how will you, if you come back to me with an answer, Sophie, then if I post it on the forum, then we can make sure that it gets back to everybody, if that's all right.
And it might be helpful, Lorraine, for you to link up specifically with Jane, who will be able to help. I think the issues in different trusts have been different, so we might be able to pull out some themes.
Lovely, thank you.
But if you're happy to put your email in the chat function, then I can link you up with Jane.
Super, thank you, Sophie. Juliet.
So I was just going to say, sorry, I feel like I've spoken a lot. In two things. In our area, we had an escalation of non-attendance tracker, which was held by me initially, for those that, so in September, for those young people who weren't attending school, even though being offered to attend to school, and then we would identify why that might be and get somebody to contact the families and negotiate what else needed to happen to make that successful. But I'm aware that that's probably fallen off the to-do list by a lot of people with the second lockdown as well. So but that was useful. So when Richard was saying about how many young people might not be attending school, and Anna's point about there may be an increasing number again about anxieties about attending school. So I'll take that away, that I'll update the non-attendance tracker. But also I've put in the chat about the SEFT. It says in the guidance about the removal and addition via the SEFT, and Dr. Pandey and I don't know what that is, and wondered if anybody might be able to give us some insight into that.
I'm looking to my NHSEI and NHS digital colleagues here. You've developed a lovely acronym. What does it mean?
I'm trying to guess what it might be. Is it in the one that I shared?
Did you say SEF? SEF?
SEFT is my understanding of what it is. And it was in the letter about updating the shielding and advising how to update. So that CO, whatever, 58.3 letter, I think it was in preparation for cleaning up the list for the end of the first lockdown.
We'd have to ask NHS Digital.
That sounds like something else we might have to get back to you on. Let's just assume you did the right thing, Julia, even without knowing what you were doing.
It's in the Urban Dictionary for boisterous or disorderly conduct.
Thanks, Sally.
Because SPL is the acronym for the shielding patient list. That's the one that gets used a lot, doesn't it? So
yeah, no, this was directing people to remove and add children off the list, but using the SEFT.
It must be like
it's in the appendices of that letter.
Okay.
We'll add that to the list of things we look into.
Thanks very much, Sophie. Oh, there you go. Safe electronic file transfer. Rajesh thinks. See, even without his microphone, he's making one of the most valuable contributions this afternoon. Right. Anything else? We've got a little bit of time left, but I don't want to, you know how good I am at wittering on and filling time, but I do not want to do that if actually you can go early. Lorraine.
Amanda, I know we're going to follow up on some questions and we're going to share the recording, but it just might be helpful for those who weren't able to make it today to make sure there's no additional questions so that we could add them, so we don't keep going round and round. So for those on the forum that may have anything else, I don't know if it's helpful or not, but I just don't want to keep spending a lot of time on this when we can, we make sure we get the information to people.
Yeah, absolutely. I know that Marie, are you there? Because you did me a really helpful summary, didn't you, of the issues that came up on the forum around this?
Yeah.
have you got that to hand by any chance? And can you see whether there's anything that we haven't talked about yet? In the meantime, can I just check with Lorraine and Anna whether or not those are new hands or old hands?
Old.
That's okay then. I'm not sure. Either Lorraine is concentrating very diligently or she may have frozen. How are you getting on there, Marie?
We don't need to do it now if people want to go on, but it's just to remind you, Amanda, that's all, because we've had a long day, everyone.
We have had a long day. So what do you want to do, Lorraine? Shall I send round the list of questions that we haven't answered to our group of presenters, and we'll just make sure that we get any final solutions? That doesn't sound good, does it? I'm sure that's been used in a very bad way in the past. Right. Anyway, I clearly am now tired and wittering, so I'm going to draw us to a close unless anybody shouts at me and tells me there's something desperate that they want to add in. Thank you very much to everyone who's presented today and helped us to provide some clarity and light on this issue. As usual, you are an energetic I've never come across a group of people who can find a solution to anything I throw at them. And not only did we have one solution, we had three. So thank you so much, guys. And thanks to NHSE and NHS Digital for turning out in force, and to DFE as well, and to DHSC. We did have, we were very joined up this afternoon. I'm very impressed with us. So thank you all very much. If I don't see you before, have a great break at Christmas, and no doubt we will be back to discuss some other very urgent coronavirus issue in January. But until then, take care, everyone.
Thank you, Amanda.
Thank you. Take care.
Thank you. Bye.